Hello, everyone. Thanks for being here. We'll still have some folks trickling in, I'm sure, over the next several minutes as we expected maybe 15 or 20 additional folks. So, but we're glad that you're here for our What's Up Doc event. My name is Tessa Espinoza. I am the Vice President and Chief Philanthropy Officer for French Hospital Medical Center. And I oversee the foundation. So being a nonprofit hospital, we depend on community support, and we're so grateful for it. And we can do so much more with the support of our community. And I also oversee the Hearst Cancer Resource Center. So it's a great privilege to work at this wonderful institution and to fundraise for such a worthy cause. Today, we are going to hear from CEO and President Sue Andersen, and also from our head of our hospitalists, Dr. Piyal Patel. So we're excited to get going with our presentations. You'll learn a lot. State of French Hospital, kind of a big deal. So we have exciting updates to share with you today. But as is the tradition with our organization, we start all of our meetings with a reflection. So I couldn't miss the opportunity to reflect on the day today, given that it is St. Patty's Day. I thought that it might be interesting to note who St. Patrick was and some of his history. So St. Patrick was kidnapped, interestingly, by Irish raiders and spent 6 years in captivity in Ireland, working in very harsh conditions. He eventually escaped. And then when he returned home, he decided, actually, I'm going to voluntarily go back to Ireland and I'm going to serve the community. So he spent the rest of his life caring for the vulnerable and supported the outcast and the forgotten in Ireland. So in many ways, St. Patrick embodied what we might today recognize as a public health calling. He went where the need was greatest, he stayed when it was hard, and he believed that no person should be left without someone to care for them. So the symbolism of the shamrock is also interesting because it's three distinct ideas or three distinct entities that are brought together with one shared purpose. And so I thought the symbolism of the shamrock is also interesting because we have, one leaf might be the patients who, that's the heartbeat of our community. That's why we're here today, why we gather. One leaf might be for our caregivers, for our healers, whose hands and hearts show up for our patients every day. And one leaf is for the community, for you all, and for this place, for French Hospital, who has served San Luis Obispo community for 80 years and is a steady home for healing for all those that walk in its doors. So that is the reflection for today. And with that, I will turn it over to President and CEO Sue Andersen.
Thanks, Tessa, and happy St. Patty's Day. Thank you for sharing a little bit of it with us. As Tessa said, I'm the president and CEO of not only French Hospital, but Arroyo Grande Hospital and Marion Hospital. And I will talk a little bit about our service area today and all that we provide and all, but hopefully this will be interesting to you. And after Dr. Patel speaks, we'll take questions. So hold those questions for just a little while. To start with, Common Spirit Health is our parent company. And a lot of people don't know anything about Common Spirit Health. And to tell you a little bit about us, so we were Dignity Health. And Dignity Health had hospitals in California, Nevada, and Arizona. Catholic Healthcare Initiatives had hospitals in all those other states except for Utah. Utah's come on board since we came together. In 2019, the two organizations merged because they felt that we needed to have a voice on a national scale. There was a lot of talk about the Affordable Care Act and affordable medicine and everything, and they wanted a seat at the table. And Dignity was kind of small, only representing 3 of the states. So we joined together, and then in 2020, what happens, COVID hits, and we stayed Dignity Health, they stayed CHI, even though we were all one corporation. But Common Spirit is our parent company. Our communities kind of knows us as Dignity Health, but I'm just telling you about this because at times you might hear that name and it might be confusing to you, but that is our parent company. And to tell you, the name came from a biblical script talking about the common good and taking care of all people, and that's really at the heart of what we do. And some of the sisters, most of our hospitals were started by sisters and sponsoring congregations and all. The interesting part to me is that we can reach 1 in 4 across our nation to provide medical care. So we take that very seriously because anything we do could have a big impact across this country. So our local area, that's mainly what we're here to talk about today. And really, truthfully, in my mind, healthcare is local. It's all about, in our hospitals here, we take care of our families, truly. I mean, all of my family's been in our hospitals, my neighbors have, and so that's what we pride ourselves on. We want to have quality facilities because we're taking care of our greater families. So we have the 3 hospitals that I think all of you know about, but we also have 42 physician offices. We now have over 250 providers, and I'll talk a little bit about that because I know everybody is always asking me, how do I get into a physician or a primary care? And I'll try and tell you what we're doing about that. We also have 4 urgent cares. We have 2 ambulatory surgery centers, soon to be 3. We will be opening another ambulatory surgery center along with our physicians. It's a joint venture that we have, and we will be opening one at the new cancer center that I'll talk about in a minute here in SLO. We have 3 cancer center sites. We have the brand new one that we're doing here, plus 2 other sites. We have an acute rehab unit down at Arroyo Grande Community Hospital, which takes care of patients who are post-stroke or post-amputation or need a couple of weeks to learn their balance and all. They do amazing work down there. And then we have a 95-bed skilled nursing facility down in Santa Maria. We also have our own home care hospice and home infusion that goes from the outer areas of San Luis County down through Santa Maria and Lompoc area. So covers quite an area, but we really feel like we can help take care of patients from their early days in delivery to end-of-life care. We're here for our community. So what are we doing to help with physicians and recruitment? That is one of the biggest questions I get. And believe it or not, in the last 4 years, because 2027, we're just starting fiscal year 2027, but we've recruited about 151 new physicians to our area. I know a lot of times you don't quite feel it, but we are really trying to bring new physicians into the area. And then in addition to that, we've also recruited a total of 60 advanced practice professionals. So those are PAs or nurse practitioners. I think healthcare across this nation, you're going to see more and more nurse practitioners and PAs that are joining physicians in their offices so that they can cover the need in the community more fully. So I expect this number is going to go up significantly in the next couple of years. And also just one other comment about that. That's what kind of makes it exciting that ATSU, AT Still University, is moving into San Luis Obispo. They're graduating right now about 90 PA students a year. And a lot of people don't know who ATSU is, but they have huge medical schools, one in Missouri and one in Mesa, Arizona, that train physicians. So this is a new campus for them in California, and they're taking over the old Mind Body building off of Tank Farm and Broad. And we're excited because I'll show you in a minute, we're going to be out there too, and that will become kind of a whole medical campus. But as they graduate more PAs, we're hopeful that we can bring some of them into our community. And then we have our own residency program. So every year we graduate 6 family medicine physicians and 3 OBGYNs. They go through, so the family medicine program is a 3-year program. These are all residents that have graduated from medical school, and they do their residency program with us. And then we have a 4-year OBGYN residency program. So our physicians here train all of these to be physicians in in the greater United States and all. Our hope is to keep as many of them here as possible. This is a real pipeline for us, for physicians in this area. And we're very proud of these two programs. It's brought a whole great dynamic to our community. And then here's like for French, we have been recruiting. I can tell you what we have new. We brought on new cardiologists in the area. We just brought a new ear, nose, and throat specialist to the area, Dr. Vandegren, and he actually was down in the Santa Maria area, moved to North Carolina, and then decided the grass wasn't greener on the other side and wanted to come back. And he's back in the community. He is a tremendous ENT, and we're very happy. He will be working in North County and also down here in SLO. We have added new docs in emergency medicine and anesthesiology. We can't do surgeries without anesthesiologists, so that's been a key recruitment effort for us. Continuing to add to primary care. The trauma surgery that you see there is mostly for Marion because we have a trauma program there. We're a level 2 trauma center. But here we're also looking for additional OBGYNs. And then our investment in our future. So here at French, a lot of times we talk about our tower project and all of that, or Adventist, I know, recently announced their project. But we want the community to know that we have put a lot of money into French the last few years. We built a brand new emergency department. We have 2 brand new cath labs here. We put in a new PET CT. We did boilers and chillers and things like that none of you care about or see, but when they don't work, it's a problem. We brought in a Mako robot for our orthopedic surgeries and a lot of other surgical equipment for neuro and GI and other areas. We're always very proud of the care at French Hospital. I have to tell you, we are so proud of this hospital because French is one of the few hospitals in the nation that has a straight A with Leapfrog, which Leapfrog is the rating agency for quality and safety for hospitals. French has never gotten anything lower than an A, which is pretty amazing because they take the data. Yes, we fill out a report to turn into them, but also they take it from Medicare data. So it's not data that we turn in, it's data that they get from other outside sources. We also receive a 5-star rating. You can see it online. If you Google Medicare CMS, you can see that French has a 5-star rating. There is no other hospital in California that has that kind of rating. And you can see that sign says one of the top 6 hospitals in the nation. And I think it's actually one of the top 5 that have those kind of ratings, which is truly amazing. Yeah. Truly amazing because, little French hospital in a way, it's amazing that we are able to do such high-end work and have those kind of grades and rankings. And then, it's kind of fun that we just got best hospital in the Tribune's best hospital. Best survey. We'll take it. So, strategic focus, where are we going at French? And I know everybody asks about this because this has been a huge project for the last few years. So, what has happened is that this started in 2016, 2017, and the plans were drawn according to the codes at that time, and then COVID hit, and we had to do environmental impact surveys, like the butterflies that live in those trees were an issue and all. And so we have been working on those things the last few years, but COVID did set us back, I will admit. And then just the funding, as you delay projects, as you know, what was a $100 million project is now a $280 million project. And there's a lot of reasons for that. Some of it good. We put more money into this project because we have more things that we're going to do as a part of it. So what we're here to announce, so what we're excited about is we finally have full approval for this project within our organization to fund it, the $280 million. And then on top of that, what's happened over the last couple of years is all the plans had to be re-updated because they were done on 2016 code for the state of California. They had to be updated to the 2022 code. And we finished that project. The deadline to do that and turn that into the state was December 31. So we worked with architects, all of our directors and everybody worked with the architects over the last year to really modify the building and really get the plans drawn according to the newer code. And we did complete that on time. So the state has our plans. They're just waiting for us to say go, which we should be doing within days. And then it'll probably take them about 8 months or so to get through the plans and work with our architects back and forth. And then we'll have 1 year to start the program and break ground. We'll do the parking. There's a parking deck, which will be done first and then followed by the hospital building itself. The exciting part, so where we're at right now, in fact, is this building right here. So the new hospital will be right next door here to the side. And you can see we'll have like a roundabout in front. So the back of the hospital is now going to become the front of the hospital, basically. You'll still go in the other side for emergency care, but anything else you'll be coming in this side. When you walk in the first floor here, it's going to be mainly a really beautiful cafe with all of our dietary services for the whole hospital. It'll include also all of our outpatient and inpatient imaging services, our registration areas, a lobby for patients, all of that. The second floor is going to be all critical care. So it will be a brand new 20-bed ICU, and it will include another 8 rooms that will be like a step-down level. So a little less than ICU care, but a little more than telemetry care. And then our top floor here will be, this top floor will be all med-surg telemetry. And these will all be private rooms. Every room in this building will be private rooms. What we will end up with here, well, in fact, I'll show you. Here's a schematic of what the room will look like. So the nice part is we'll have, see like this couch here. So when a patient is in a room, they'll all be private. It'll have its own restroom. And also it will have a couch that can come out and make into a bed if a family member wants to stay with their loved one, which is so much better than what we have today. And so that's very exciting. In total, we will have 108 private rooms. So right now, to tell you, we have 51 rooms here. And we run an average daily census in the 70s, sometimes up into the 80s. So basically, everyone should be able to get a private room here with 108 private rooms. But we also, if we have another pandemic or God forbid something happens to Sierra Vista or something, we can take up to 160 patients with the new building plus remodeling the old building. So in the old building, here I'll go back to the pretty slide here with the buildings. In the old building, we will be remodeling the old ICU area to be private med-surg rooms, so we'll get additional med-surg rooms out of that. We also have to do work to expand our pharmacy, expand our supply areas, all of that. But we will be doing some extensive rework within the old building too that's included in the price of this new tower building. And then just to tell you the other thing that we're very excited about is our comprehensive cancer center. You've probably seen some information about that, but that is at Tank Farm and Broad. We are the building, like right now it's surrounded by fencing and everything. There's all kinds of construction going on there, but it is an old mine body. It was mine body was in that building. There's, if you know Tank Farm and Broad, there's a Shell station there, and then there's a building that faces Tank Farm. That's our building. The ground floor is going to be French Hospital's imaging services. So it'll have all different, it'll have MRI, CT, everything, mammo, ultrasound, everything that our cancer patients may need. That'll be on one side downstairs. The other side will be our Hearst Cancer Resource Center. And we're very excited about that, a brand new area. And to have the Hearst Cancer Resource Center be right in the middle of all of our cancer services and oncology services, we're really excited for the community about that, because we can be right there for patients when they're in their greatest needs or finding out about something. We can really help them walk through that journey. Also in this building will be a surgery center. That's something that we own with physicians. Right now, if any of you have been down or know Coastal Surgical in Pismo Beach, this will be Coastal Surgical North. But it's really exciting because right now, some of our physicians have a backlog of patients. I hear it on, like, orthopedic surgeons will say, well, I can't get you in until May for a surgery and you're hurting, your knee or your hip is killing you. This will add a few more ORs to our community, so we should have more capacity to get patients in sooner. In addition to that, we will have our infusion and our oncology services upstairs. The Associated Surgeons, the Hayashi group, will be in this building, as will the urologists will have office in here. There will be a radiation oncology center, and I think I got it all. But we're very, very excited about this project, and right now we're on track that the surgery center could be open as early as October. And all of our areas, imaging and everything, should be done by December. So that's the track we're working on right now. But we expect by early 2027 that the full building will be open at the beginning of 2027. Really, hopefully in December of 2026. So that project's rapidly moving along, and we're very excited about that. Other things, some of you that go to Coastal Cardiology may go to a little bit different location if you come for a stress test or some imaging, cardiac imaging. We just completed a project and opened today a new cardiac imaging center on the second floor of our medical office building right next to the hospital. That's a very exciting project. Those of you that have been there in the past, it was in the basement. And this is brand new. It's beautiful. We spent a couple $1 million actually putting in this new imaging center. But we're very excited about it. I think it'll be a much better experience for patients. And then we have to do seismic upgrades required by the state of California by 2030. All hospitals within the state are supposed to meet the 2030 code for seismic. It doesn't, our new building will be up to code, but our old building here, we have to spend about $35 million to bring it up to code. My 3 hospitals here, it's about a $101 million project. And the reason I even say that is because it's a real concern among hospitals in California, because this requirement is for all hospitals in the state of California. And there are a lot of hospitals that are saying to the state, we don't have the money to do it. So what are you going to do? Shut us down? And I asked our legislators, I've talked to many of them and said, what are you going to do? And they said, well, we don't know yet, but we don't want to be the ones to vote this down and then have an earthquake happen and the hospital falls down. And I understand that, except that we all meet the 2020 seismic upgrades that were needed. And I think a lot about, well, if there's that bad an earthquake, that, the hospital will be left standing, but we may not be able to get staff in or physicians in to take care of people if it's that bad. Hopefully, God forbid, hopefully we never have an earthquake like that. But this hospital has survived many earthquakes, but we are going forward with the project because it could, if we don't, it could jeopardize the tower project and everything else we're doing. So we are moving forward with those upgrades, but you won't notice them when you come to the hospital. Unfortunately, it doesn't help us with our multi-patient rooms. In emergency room enhancements, we're putting more privacy in the emergency room waiting area for triaging patients and all. And then the acute rehab hospital in Arroyo Grande, I just talk about that because we refer a lot of patients from here down to our acute rehab. Our current acute rehab is a 20-bed semi-private room that's part of Arroyo Grande Community Hospital. Our biggest problem there is that we have a waiting list to get in most of the time. It's a very popular place and it does amazing work in a very small space. And so our plans are to build a full acute rehab hospital. It'll have 40 all private rooms. We're doing that in conjunction with LifePoint, who runs acute rehabs all over the country, including ours at Arroyo Grande. We're going in partnership on this, and that project would have already broken ground probably a year ago, except that we found Indian burial grounds on the property. And so that has caused a delay in it. Over the last year, we've been working with the tribe to figure out how they want that handled. And we're almost there. We have a complete agreement that we just finished up agreeing on how things will be handled as we go forward with the construction. So we're excited. We should be breaking ground very shortly on that. And then we continue to upgrade our equipment, and we always want to recruit more physicians. It seems like we have a non-ending need for more physicians. But I will tell you this, because a lot of times I'll hear people say out in the community, oh, well, I need to go to Santa Barbara for my care. I need to go to the Bay Area or something. And I want people to know that, I use the physicians here, the surgeons here and largely because people want to live here. Just like we all want to live here, our physicians want to live here. They come from all over the country. Chicago, the head of trauma down at Marion is Dr. Soholm. He was the head of trauma for Temple University for 17 years, and he was tired of the gun and knife club there, and he said, I just need a change, and he came here, and he has taken over and really developed Marion's trauma program over the last 3 years. But those are the caliber of physicians. We have doctors that graduated from Johns Hopkins, from Stanford, from all across this country, but they want to live here. They want to raise their families here. So I would say, look at the CVs of our physicians before, you go look in another area. As far as I bet you, I will put them up against any physician up and down, north and south. And then lastly, just building a healthier community. I've talked about some of our challenges like the seismic requirements by 2030. You all have heard about taking away funding for undocumented, which still means they're going to show up at the hospital. They still will have babies. We're concerned about a decline in the roles of Medi-Cal, because usually that means that they're not being covered anymore. They're uninsured, or the recent thing, what's happened in the last 6 months at the federal level, where they've taken away the subsidies for the Affordable Care Act. And where that hurts us is people then choose lower insurance levels because they can't afford it, or they choose no insurance, but they're still going to need care. They're still going to show up into the ERs. So I'm not making political commentary. I'm just saying that to make our hospitals strong, we're here for everyone, no matter what. We take care of everyone. We will not turn someone away. So we will have to absorb that if there's no funding for it. So I just tell you that to educate you. So when you're talking to people, you can advocate on our behalf as far as the need for support of our hospitals. And so we're going to leave the questions for the end, but I am going to, I won't jump the gun here. I am going to turn it over to Dr. Piyal Patel. Dr. Patel is our medical director for our hospitalist program here at French. And, a lot of times people used to say, well, what is a hospitalist? I think people understand it a little more than they used to, but it used to be years ago, that your primary care physician came in and saw you at the hospital when you were here, and it was a nice relationship. they knew you, they knew your whole family and everything. And it's just not that way, unfortunately, anymore. And they don't have the time to support a practice plus coming around on patients in the hospital. And what's really nice is now we have physicians, a team of physicians that are 24/7 dedicated to our patients who are here. We always have physicians in-house, and Dr. Patel is going to talk a little bit about that.
Thank you, Sue. So as Sue mentioned, my name's Piyal Patel. I've been in this community since 2010 and been a hospitalist since 2011. So thank you all for taking the time out of your day to join us and learn a little bit about what my team does and how we contribute to the community. So just some statistics from a national standpoint, and then more so from a California standpoint about the need for primary care. 2036, it's projected of the physician shortage to be about 20 to 40,000 for California alone. By 2030, which is not too far down the road, there's about 10,500 need for primary care physicians. So that puts you roughly at 1 in 4 in Californians in the area that's considered designated as a primary care in a shortage area. And this is by definition from federal and state standards. More so, how does this affect San Luis Obispo County? So here we are recognized as a area that is insufficiently has access to primary care from federal and local levels. I'm sure that all of you feel that, as well as your family members. Morro Bay in particularly is considered medically underserved. And some statistics here for you, the ratio of primary care to residents that we have here is different from an optimal benchmark. So this unfortunately trickles down into, what you're experiencing on the outpatient side and how you end up in the hospital area. Oops, sorry. So how this impacts you, you have longer wait times with making appointments with your primary care physicians. You cannot get your routine physicals done. This prevents you from getting same day appointments, which you may be able to have gotten before. You're not able to go in urgently to see your primary care. It puts a stress on the emergency room as well as the urgent care setting. You have urgent cares that are impacted by seeing minor cases that maybe your primary care physician would be able to, take care of. The ED, the emergency department, is seeing flares of chronic conditions. So not just your acute process, but now they're having to deal with, your chronic issues as well, because so much time has elapsed before you've been able to get that addressed. And that's leading to overcrowding in the emergency room. So you're waiting longer to see a physician to kind of help take care of you. And then what happens is you have an acute illness, and then your chronic condition, like your heart disease or your blood pressure, cholesterol, mental illness, that all compounds into it, and it makes the whole situation very complex. And what this means is, like I mentioned before, there are certain things that get missed from a patient care preventative care standpoint. There's cancer screenings that may get missed, blood pressure management, some cardiovascular disease management. You're seeing an increased cost to you inadvertently because you're having more frequent visits to the emergency room. You can't see your primary doctor. Your hospital admissions rates are going up because you're presenting more ill than you would have been. And then we're having that's causing you to have an increase in your cost of insurance premiums down the road. From a physician standpoint, we as physicians went into medicine because we wanted to take care of you. And this puts a lot of burden on us because when we are forced, especially in the primary care setting, to see you in shorter time intervals, that relationship becomes fractured, right? And we have a depersonalization between the physician and the patient because we are supposed to see people, certain time intervals to get in the day because of the volume. So this is not a good situation both for you, for the community, for you, yourself, your family, as well as on the physician side too. And so that's why you're seeing, physicians that may have come in all bright-eyed, bushy-tailed after a couple years down the road say, this is not what I signed up for, and trying to find their path into a different way. But there are still some of us that stick around. So don't lose hope yet. So what happens is, you try to take care of your chronic disease. It's frustrating to get into a specialist or to your primary care, and then you unfortunately end up in the emergency room, a nice emergency room like French Hospital, and you go past the emergency room and the physician says, I think you should stay in the hospital. We can kind of tune you up, take care of these acute things, maybe set you up for some care afterwards, and that's how you get admitted to the hospital. So this is where our team comes in, and our role as a hospitalist plays into factor. So we are a group of physicians that specialize when you are strictly admitted to the hospital. So we have no outpatient offices. We work shift work, so 12-hour shifts. And like Sue mentioned, we are in-house 24/7. So we have 3 physicians on during the day at French and then 1 at night. I'll be the physician on tonight. So, that just kind of tells you that we are available 24/7. And most of our training, most of us are internists, internal medicine trained. We have family practice physicians that come and are very heavily focused on hospital medicine. They've trained at Marion, in their family practice program, and have taken a particular interest in hospital medicine. So we welcome them to come join us as well. And we appreciate, what expertise and the broad range of knowledge that they are also able to provide for us. So these are kind of it's a pathway of what exactly happens and what do we do for you in the hospital. So you get admitted to the emergency, you go to the emergency room, you get admitted, you get a diagnosis, we are involved actively in treating your acute illness. We manage on top of your acute issue, we manage your other medical issues. So you may have high blood pressure, cancer, other heart disease, other issues, kidney function, renal function. So we take all of those into account and co-manage that with your acute illness, the real reason why you were brought into the hospital. We coordinate the tests that are done, the procedures. So we're kind of like the quarterback of your care. So we will pull in subspecialists, to come in to kind of tell you, this person has an acute issue. They have a cellulitis or infection in the leg. Can I have some guidance on antibiotics? Are they going to need outpatient antibiotics, whatnot? So we'll coordinate specialists coming into the hospital to help with your case. We also communicate with you as a patient as well as with your family about, the state that you're in, what kind of care is being delivered while in the hospital, what the goals are, what is the expected date of discharge from leaving the hospital, and then what will you need afterwards in terms of follow-up care with subspecialists, things like that. And that brings you back to the discharge where we are able to expedite quite a bit while you're in the hospital setting. I know that it's frustrating when you go to your primary care and they say, come back and, we don't have an appointment for 6 months. But if you get admitted to the hospital, we can help expedite that appointment, so that you can be seen sooner rather than later. So what is the benefits of having us take care of you versus your primary care physician who's known you forever take care of you? So the good thing is for PHC, providers on the outpatient side, they have access to our records. So they are able to, when you come in the hospital, they are able to see what we do. They look at our notes. They're able to look at your studies, your labs. They are they can access that. There is no special need for communication that, that says that you need to look in here because they have access to that. So we're able to shorten your length of stay in the hospital by a half a day to a day. We have 24/7 physician coverage, so we're able to address acute issues. If something happens, acutely in the hospital, we're there to respond right away. We can coordinate with some specialists, and most of us 90% of my phone is filled with subspecialists in this area. So we have their cell phones. We're able to communicate with them and say, I have, so-and-so that's in the hospital. They're diagnosed with this. Can we get them in to have them be seen? I just want to put this on your radar. So we're able to send that communication. We're able to decrease your readmission rate because we're practicing by hospital-based protocols and best practice guidelines. So all of us are very well versed on how to manage acute illnesses like atrial fibrillation, pneumonia, things like that. Those are our bread and butter that we see all the time. And like I mentioned before, we are able to, kind of tell specialists that this patient came into the hospital for this acute need. They do need expedited workup. Is it possible for us to have them seen sooner than later? And we're helping, we're able to facilitate that most of the time. So this is just our hospitalist team. Like Sue mentioned, we are your neighbors. So you'll see us at Costco, you'll see us at the gas station. You may not recognize us, or we may not recognize you because we are not in a hospital gown, but that's what's special about our hospitalist team at French. We like each other as physicians to work together. We work very intimately together. We've been a very core group for as long as I've been here. And we have a special relationship with the consultants because our core group of physicians has had a long-standing relationship with these consultants. There's a level of trust that's there. And that allows us to have some leverage to help advocate for your care. This may be different than if you go to other hospitals around the area, but that's what's special about our team here. And this is just kind of a fuzzy snapshot of what we look like. And our team is always growing. We're always looking for, help in any way or shape possible. People who want to come in and we have physicians that come in from Chula Vista all the way down, come and do 4 or 5 days with us and then go back. But the majority of us are living in your community. We are your neighbors, and we enjoy delivering care to all of you. The other unique thing about our team is that we do collaborate really well with the emergency room department. And this is because we're able to communicate very seamlessly with the two departments. The medical directors, myself, and the ED medical directors communicate on all problems. We're able to help with inter-hospital transfers. So if you're at Arroyo Grande, you need some care at French, we're able to help expedite that. And then there's some things that are important to you as well as the hospital with sepsis, management, to adhere to our hospital-based guidelines, as well as to help with your patient experience of making that smooth transition of seeing you in the emergency room and then having you as an outpatient, as a patient in the hospital. So I wanted you to take away some practical things because you don't need to hear it. You've heard like what I do, but when you come in the hospital and you're admitted and we see you and we say, okay, it's time for you to discharge. If I was a patient, this is what I would pay attention for on my discharge. So this is something practical for you to take away. And that is to make sure that you have your medical records and your imaging. You may not get care here locally and you may have to go out of the area for subspecialty care, but it's really important for you to obtain your own medical records. You can do this by contacting the medical records department, or right before your discharge, you can talk to your nurse and say, hey, what do I need to do to get my medical records? That includes imaging of your disc, if that's available, because when you go to a tertiary center or a university center, they're going to look at the report and they're like, okay, that's their opinion, but they want to see the images. And so if you have that disc with you and you take it with them, you're able to give them that extra layer of them uploading that information. Ideally, we'd like all the health systems to communicate and all this be in one system. And French actually does have a very good relationship with Stanford. So all of Stanford's records are accessible to us. So that's very good and good information in the back of your head that if you do go to Stanford, we are able to access those records and they are able to do the same, but it doesn't happen everywhere else. The other thing is once you get discharged from the hospital to obtain your medical, which home meds you will be on and which meds you will continue moving forward. and to keep a copy of that list so that if you go to your primary care doctor and they say, well, what did they do in the hospital? What meds did they change? You can give them their list and they're able to kind of see that. It also will help you to keep a copy of that maybe in your wallet or, with your significant other, just have it printed out. Because when you go to the emergency room and they say what medication you're on and it's 3 a.m. and all the pharmacy's closed and, someone might be confused, and someone is able to give that list and say, here it is. And we're able to kind of say, we need to be on this or not this, and, kind of make a judgment call that way. And then also to really look at your follow-up and specialist appointments. The care coordinators who are in charge of your care to help with your discharge while you're in the hospital can help with this. Usually the physician will say, okay, we want you to be seen within 1 to 2 weeks. And so, just diligence on your part to advocate for your health, to say, when can I get in to see this specialist? Sometimes we're able to make it right before you leave the hospital. You're able to walk out of here with the appointment time and date. Sometimes if it's a holiday or a weekend or there's, other factors going on, offices are closed, then we're not able to do so. But just to pay attention to when you need to follow up. And then also lab imaging and appointments, when you're able to, when do you need to get labs rechecked? Who is going to review those labs? And what is going to be changed afterwards. So these are all things that hopefully are useful for you from a practical standpoint that we see that would be important to communicate. And that's about it.
Hey, we're happy to,
I just want to really quickly also introduce Dr. Tom Mendegna, if you could wave. Tom is our chief medical officer here at the hospital and also over the Central Coast market. So he oversees 7 hospitals as chief medical officer. So in addition to questions for Sue and Dr. Patel, please feel free to
turf them all.
Yeah. What's that?
We can turf them all.
Yeah.
We can pitch the really hard ones over
Sure.
to Tom, but if any of you have questions as well from his perspective, I'm sure he'd be happy to chime in. Thank you. So yeah, any questions, feel free to.
Yeah, we're happy to answer
Yeah.
questions. So I don't know. Okay, we'll start here.
How do you collaborate with the other medical groups like Adventist Health and so?
Oh, yeah,
Is it
we collaborate with everybody. So I'm trying to think of examples, but most of the physicians in this area go to all, both of the hospitals. We currently, both hospitals they were on the same computer system. Now, I think they're switching before we are to Epic, but ultimately we will all be on a very similar computer system, which helps us talk to each other. But we have, even for the physician offices that are not part of our system, it's really nice for those 42 offices I told you about that we have in the area. If you go to a Dignity Health office, then you have your portal, and that has all your results and all from your physician, from your lab work, from your hospital visits, whatever. But the nice thing is we also have work that we do. So even with independent groups where they're not part of our system, they can download our records from their hospital stay right into your medical record with them. So most of them should have all of your information.
When you come from the ER, say you were at Twin Cities, right, or Sierra Vista, and you come to the ER at French, we do request your medical records right off the bat. So if you were previously hospitalized, it will come in a fax, and then we get a big packet that we sort through, and while you're in the hospital to look at what is important and what's not.
Yeah.
Well, I want to thank you both for your presentation. You both are really good presenters. So
Thank you.
when I ask my questions, it's not that, gee, they're going to seem maybe a little silly in the surface, but that was really good. Could you come over and join us for dinner tonight? Both? We got about 4 hours of questions. But for both of you, I'll throw both questions out. So Dr. Patel, one of the things you had in there was physician burnout.
Mm-hmm.
Well, I can understand it. In fact, 12-hour shifts. My career was 8-hour, 9-hour shifts, and I was burned out. So are we overworking our local physicians? I don't answer yet, because I want to give Sue hers, and then Sue, $280 million for this new project. My wife and I are donors and.
Nice, we appreciate that.
We're not leaving anywhere near that.
Yeah, we have naming opportunities for anyone who has an extra 15 million. Your name can be on the tower.
So Tessa, make sure I heard that. So what it is give a little sense of how in the world you get that when I've been in presentations here when we talk about Medicare and the lower reimbursements. But are we flushing money? So please, if you both.
Yeah, I'll let you go
Okay.
first. And
Yeah, yours is a little. So 12-hour shifts. We have been trained that way from the get-go. So the number of hours spent, working to someone who has not been doing that since they've been in medical school or residency might be, a little bit more than normal. The way that we prevent from physicians burning out is for our leaders to check in with the physician, and see, what kind of things can we do to make their day easier? Are there hospital system process operational things that can make the day go by better for them? Because it's not so much the hours and the load, it's more little frustrations along the way, like, the analogy of little pebbles in your shoe that accumulate to this, massive blowout eventually. Now, we did experience a lot of that with COVID, right? A lot of stress on physicians and the hospital system and the way things operate, and then afterwards. So there was probably a curve of, people that were ready to retire that are now going to take that step. But in terms of, 12-hour shifts, ER does similar type of shifts, surgeons work a lot. It's the nature of our beat, it's the nature of what we do. It's a privilege. And I think that as a medical director for my team, my responsibility lies in making sure that I check in with them, make sure they're okay. Let's see what I can do for them to help them get through those times.
And so in regards to answer your second question about the hospital and how we're going to afford this and all that, I know it's kind of the wrong time to be doing this with the headwinds we're facing, but that said, we are very fortunate here. Actually, all three of our hospitals here, we're very fortunate in that, as you know, as you look around this community, we have a lot of, our biggest payers are Medicare and then commercial insurance. We have very low Medi-Cal. And so French is able to do well enough that off operations, we've been able to pay down our debt over the last few years. Just last year, we paid it down completely. So we're now debt free. So we will be taking on debt for the new tower, but at least we know that we're going at it without already having a bunch of debt too. And then in total, so usually what our organization likes to see is that they don't want to build a building and spend that kind of money unless there's community support for a project. And so they, in most of our larger projects, we try and fundraise for about 10% of the project, and this is no different. So from the beginning, our foundation has had a goal of 30 million to raise towards this project. We actually have already raised 22 million. Some of that was in planned gifts that we haven't gotten the gifts, but we have several million in planned gifts. But we will be, once we roll out the timeline on this project and all, we will be fundraising for about at least another 8 million. Anything above that would be wonderful because it would help with the debt load that we take on, but also help us be able to do some other niceties that maybe we can't do that aren't a part of the project. I know all of our cardiac team is saying, we need another cath lab, we need, so those kind of things we could look at doing if we have more donations than what we currently have. So hopefully that answered your question.
So the government is not funding this?
Only in the sense that they pay us Medicare and Medi-Cal or government funded, other than that, no, we are self-sufficient. as far as, yeah.
So just to add, just really quick, just to add to, that those are good questions, Scott. So yeah, we'll get corporate will give us an allocation of resources that we will then, have debt service back to them. But we have, if we've done some of our pro forma estimates, how many years do you anticipate it will take with the revenue that Branch Hospital typically generates to pay back that debt again and to reach that flush sort of zero debt, held again in the future? Do you think it's 15, 20 years or?
Probably 20 years.
Okay.
Pay it back.
So it's pretty incredible. I mean, to have a tower of this scope and scale, and then to know that with our revenue being as successful as it is, that, in 15 or 20 years time, we'll be back to zero debt, which is wonderful. But yes, community support is key. And then Dr. Patel too, I guess just for my own curiosity, 12-hour shifts, but it's not 5 days a week, right? I mean, it's not 7 days a week. It's not, you get, right, do you work a few days on, a few days off?
It depends. Yeah.
Okay. So, but I know you're used to it, but I guess we just to balance that.
Yeah, we are not, our shift commitment doesn't impact your care that we deliver. So I just want to make that clear. But we are, there are physicians that work, 7 days on and then are off for 7 days. So it's just everyone's expectation. Some people only want to work, 4 or 5 shifts a month. So everyone is in different stages of their career, and we have different ways that they help us out.
Thank you.
Yeah.
Okay, I think I saw yours first.
Yeah, I come from a practical, and just so you know, I always say I'd rather die going with grade going to French. Just saying that. When you talk about, you do the 12 shifts, my sister passed away a year and a half ago. She was not in this hospital, another one. And in 2 weeks, she had 8 different doctors looking at her. Every time I seemed to call and ask a question, it was like, well, what's going on? Well, I don't know. I just got her. Well, I don't know. I just got her. Well, I don't know. So I found myself having to report. I'm a retired nurse. Her hand is swollen. She started changing medication. She's had this. I called the night doctor one time. He goes, oh, I'll check on that. We should do a scan. I'm like, yeah, you think? And so I'm wondering, how do you pass off patients? Like when you're on for 4 days, say, you have the same patient. You're off for the 3 days, say a regular 12-hour shift. Come back in, you get the same patient. So does that continuity of care?
So we try really hard to generate a schedule that allows physicians to have continuity of care, right? So that if you are in for 7 days, that you're not seeing 7 different physicians. So we generate a schedule that keeps everyone, consistent as long as they have been. Now, I may see you at the end of my shift, so you're going to see another one. But that doesn't mean that the following day you'll see somebody else. We do have an internal sign-out process that we do between each other. So even on a night shift, if there are some patients that are unstable or that there's questions on, I'm going to get a report, say, hey, can you look at this on this person and this, this is what is pending or not pending. The other thing is, good point about the communication. It is very important as a patient or patient advocate to write your name and your phone number on the board of the room that you're in, and to let the nurses know that when the hospitalist comes in to see the patient, have them call me if I'm not physically in the room. And I usually say that to patients when I see them initially in the ER, that I'm seeing you right now and I'll see you again tomorrow morning. If I'm not in the room or I see your, family member before you even get there, I will call you before the end of my shift. It may not be right away, but I will give you a call. Just make sure your name and your number is there. And you can always tell the nurse that I need an update. I haven't received an update. I have a couple of concerns. Can I have those addressed? And that should not be a problem.
Now, in the rooms when you guys go in, I'm just a retired nurse, so it's one of my pet peeves. So you go in and you see hospitalist on the patient's wall, and it's like, well, the hospitalist has a name.
Correct.
Can you put the doctor's name that's staying there today? I think that's so important.
Yes.
And it doesn't happen.
Yeah, very good feedback. So if you see the word hospitalist there, we all have a name. So you can always ask the nurse, can I get clarification on who exactly is being seen? Sometimes the nurse doesn't know because they're changing shifts as well, because of who gets admitted tonight versus who's going to see them tomorrow. So for example, if I'm working tonight, I will admit everyone tonight for the next 12 hours, but I will obviously be off,
Yes.
right? So my partner will come and see that patient the next day. So that might trigger you to put a hospitalist on there as the physician, but you can always ask for clarification. Every morning we have a list that each hospitalist has a team that is submitted to the clerks. So everyone in the entire hospital knows which patient is allocated to which physician.
And I appreciate the communication you guys had because that's important, you know.
Absolutely.
Those to each other. I think that's not happening for us. Thank you.
Okay,
The new rehab hospital in Aurora Grande, where's that gonna go?
so, if you know where the hospital is, the front is right on Halcyon, and this will be right next door to it on Halcyon. There's a little surgery center that's right there. We're buying half the surgery center property. And so it will be as close to Halcyon as you can get without taking down the surgery center, really, in a way. But that's where it's gonna be.
So they'll use the services of the hospital, pharmacy and.
They'll have a lot of their own services, but lab, imaging, those kind of things, they'll probably use the hospital. And our hospitalist group that covers at the hospital will also be covering the acute rehab.
Do you have an estimated time for, like, how long do you think it would take to get that built once the ground gets
The
broken?
tower here?
Well, the rehab, which I,
Yeah, the
How do
rehab,
you figure it out?
it's within a 2-year time frame.
really?
Yeah, so that'll be a little sooner.
Okay.
You know, our building here, the original estimate was, not original, but in the last couple of years, has been 2030. I'm thinking it's probably slipping a little bit to 2031, but, you know, that's kind of the time frame we're looking at. Yeah.
Knowing that it's really complicated, the subject, my curiosity is what can this group of hospitals do about recruiting RNs, doctors, everyone that's so difficult to get here, knowing that we can't change the cost of housing, the cost of living. What is the hospital doing to add to the total benefits to attract doctors from out of the area or any other professional?
Yeah, so we're, on the physician side, I feel we're very competitive. We have to be. We have to, you know, I will say here that most of our physician practices are kind of in the negative. It costs more to run the practices than they bring in, but we can't run a hospital without physicians, so we have to do that. And also to attract good physicians, you know, they love a place, but they're not gonna come here if we can't be competitive of what they can get with, in other states and other places. On the nurse side, I will say we are so fortunate here because Cuesta College graduates about 35 nurses a year, and Allen Hancock graduates about 50 nurses a year, and we hire probably Allen Hancock's nurses, we hire about 98% of those. Cuesta Sierra takes a few of those, we take the rest, but like last year, we hired 32 of the 35 graduates. So we're really lucky. We have a constant pipeline of nurses into our hospitals. You know, we've had to train internally. We have a residency program for their first year that they're here. That has really helped us to retain nurses too. We find that when we recruit from out of the area, a lot of times they'll stay a year or two, and then go elsewhere. So we like to try and recruit people that have some connection to this area. And so, you know, we've been actually doing a much better job. Like here, we've reduced the number of travelers by half. We used to have about 80 travelers here, but we're down to about 40, and we should be down to about 26 very shortly. You need a few travelers because they fill in a little bit that seasonal work, but we'd like to have our own employees.
Is that for all 3 hospitals you're talking?
Yeah, I mean, I was talking specifically French, but,
Were you? 80
but-
for French?
yeah.
But there's probably not likely anytime soon a remedy for the rural designation for reimbursement? Sorry, that would help you guys so much.
I know.
What,
It would, and it's really unfortunate because we were in the lower reimbursement area. I mean, even to be honest, even Marion State gets a little more from Medicare than French does, which go figure. I don't know why the cost of living is, you know, as high or higher here. So, yeah, in the back.
I've got 4 questions if I can ask them. The first has to do with the tower. Originally, when it was being planned, it was a 4-story tower.
Yeah.
Now it's 3.
Yeah.
What changed?
So the original plans had 2 floors of shelf space, thinking that we would build it out in the future, that we only had money to do 2 floors, and then we'd have 2 floors for the future. We, in the last year, we've made the determination, we get 1 shot at this, we're gonna build it out, and so that's why it's 3 stories instead of 4, but it will all be built out, as well as the project now includes remodeling of the old building, because there was no money in it for remodeling of the old building. That's why it's so much higher too than it was before, because there's no shelf space and there's build out of the old building.
Okay. And then I have a question for Dr. Patel. You mentioned the PCP shortage. Is that shortage just if you account for PCPs, or does that even apply if you account for the PAs and the nurse practitioners and the others who can extend the...
That's a strictly physician, number, but you can, I think the trend now is to use APPs, advanced care providers, to kind of help facilitate and fill in the gaps there.
So we may be able to cover that.
To cover that significantly, yes.
Then, if I can go back to you, Sue, physician recruitment, this county is on average an older county.
Yeah.
In my experience, not overall, but certainly in some specialties, our physicians are older, which means that we're going to have a lot of retirements coming up. What are your biggest challenges there, and what are you doing about it?
We are recruiting more physicians. We have, in the cardiology group, we have.
That's the one I was thinking of.
Yeah, we have one that's very near retirement. We have another that will be a couple years out. But we have recruited. We've been able to recruit new cardiologists who are coming to town, and we'll take their places.
Good, because I've noticed, well, this is going to lead me to my last question. And I had a friend who did a concierge medicine because she couldn't get an appointment with a cardiologist. I've seen several physicians going into concierge medicine.
Yeah.
How is that affecting the hospitals and the medical groups, and what are you doing about that?
Yeah, I mean, I totally understand why some physicians have done that, and our physician group side is really working on that to make the experience better in the physicians' offices by adding APPs, by adding more nurses, because they were getting burnt out. I mean, they were, seeing 3,000 patients and, having a patient load over all that. And so that was causing some of them to go into concierge. I get that. The problem we have as a community is when somebody goes into concierge, they'll see maybe 250, 300 patients. So they went from 2,000 or to 3,000 patients down to 300.
The other patients have to go
And the other
somewhere.
1,700 are looking for a new physician. And so that has really hurt our overall ability to have enough providers for our community. So we're hoping by making the office experience better for physicians, like we've hired nurses who are in practices so they can just help with your prescription refills and a lot of that. In fact, Scott, I see you sitting in the back. You're a big part of that, is helping to be an adjunct to some of the offices so that we can get patients in post hospitalization and stuff and all.
Yeah. So there's a lot of good things coming for them, especially the digging element. So happy to chat more about that.
Yeah, even AI is going to make a difference in, these physicians, you're not having to write notes really, or hopefully we'll get to a point where you don't have to be on the computer while you're talking to the patient, that you can be heard, and AI will just generate all your notes. It's pretty amazing that.
Yeah, software is already out there.
Okay, so.
Oh, wow.
What, I want you to tout your discharge planners and your more about the people that are doing case management stuff, because it made it sound a little bit sort of on the easy side of, oh, well, you're in the hospital, so let's call the doctor's office and just get them to, see you next week instead of, I think there's plenty of doctor's offices where it's not, if the doctor who's getting a doc-to-doc call, they might and only might say, oh yeah, I'll get them in quickly, but then they'll forget to tell the front desk or whatever. So you have a lot of responsibility now for getting people out of the hospital and having a warm handoff, having a handoff to the to making sure that they're going to get connected. So I'd love to hear you tell how great your
No,
case
that
managers
is
are.
such a good, because certain patients, oh yeah, it's really easy, you do a follow-up appointment and they get, but it's the really complicated. I mean, we had one that was here for quite a long time with us that acted out in the whole, when you have multi-patient rooms and you have somebody that's screaming in the hallways or abusing staff and all, but where are you going, where are they gonna go? That's the problem. And
Right.
case manager is calling all over the state to try and find somebody who will take this patient for their continuing stay.
For your outpatient office visits, what you're referring to, if it's something with a subspecialist, we will call them and say, especially in oncology, a new diagnosis of cancer, I will get on the phone and say, this is so-and-so, it's a new diagnosis there, and they'll say, yeah, sure, I'll get them in this week, or I'll get them next week, or whatnot. So when it is necessary to do that warm handoff, even if you're going to a rehab facility, right? Just knowing the nuances of what happened while the patient was in the hospital and how they may act at the rehab facility, that is helpful information. So yes, it's not as easy as what it is presented as, but I will tell you that there is a significant amount of effort on the care coordinator side to get those appointments, make sure that you have a time and a date, before you leave the hospital, and that's their goal initially. And then, like Dr. Piazza is part of this transitional care clinic, which is very helpful if there is a lag time between you needing an appointment with your primary doctor or someone, because you don't have a primary and you need that, we can go through the transitional care clinic. They can have a follow-up appointment, expedite that. You can get the care that you need, meds, specialist, all of that, and go from there. So that transitional care clinic is very key that all 3 hospitals utilize.
So, yeah.
I hear a lot of really exciting projects within your footprint. I'm wondering if you have any dreams beyond your footprint or to the edges of your footprint that you're willing to share.
My dream is shovels in the ground. and we're getting that building going. That is my main dream right now. I do look forward to the day. I think healthcare in general, we have to do better, whether it's through AI or whatever. We've got to you need to be able to say, oh, I need to get an x-ray. Oh, okay, I have my order. I'm going to go online and schedule my x-ray for next week or whatever. It needs to be, navigating healthcare needs to be simpler. And so we still have, all of us in healthcare have a lot of work to do on that. And I guess that's my dream is that, it's funny, I use this as all the time, but in a physician's office, you go there and you sit in a waiting room, not a reception area, a waiting room. So the expectation is you're there to wait. And I thought, that says it all right there. Why do we have an expectation you go there and you wait? We should get streamlined where you go there, you get right in, you get what you need, and then the next patient comes or something. We've got to do it better. So we're working on that. We're trying to get better and more efficient at what we do and rethink the whole thing. There's got to be better ways.
Thank you for your person. I have a question about the new place that on Town Farm abroad. What is going to happen to the dignity health cancer care that is across the street?
Yeah, across the street, we're still keeping that building, and we're talking about possibly still using the infusion center and pharmacy that we have over there. A lot of people, you may know this, but whether you go to a neurologist or a gastrointestinist or a rheumatologist, there's all kinds of other infusions that people are getting now for a variety of things. And it might be nice to do non-cancer patients maybe in that location. That's one of the things we're looking at. We're looking at possibly putting more primary cares in that office. So we want to still use that office.
But the people that are there are going to move to the new. Okay.
They're all moving to the new space.
Okay,
Yeah.
thank you.
Well, first of all, thanks for being here and being so open and transparent with us. Really appreciate that.
Yeah, thanks all for coming.
Yeah. One observation and one question. The observation is getting fax records from other hospitals seems super inefficient. I don't even believe that I could go out and buy a fax machine today, so bravo for you for standing tall in the face of that inefficiency. But do you, as it relates to physician recruitment and retention, what's your attrition rate? How many physicians leave your practice in total every year? And do you do exit interviews to find out the why behind their transition? Because we make a lot of assumptions about the cost of living and, some people want the gunshots and staff wound clinics, and they miss the heightened sense of urgency with some of the cases that we have here. So do you do that research to find out the why, and then how do you address the why?
We definitely do, and the good part is that once people come here, especially we find that when people come here and raise families here, they do tend to stay here. They like it. They like the schools and everything. Where we have problems sometimes is people who have no family here really and come for a couple of years and then decide they want to go back to wherever their families are. We tend to lose people probably for that more than anything else. I know, Scott, I don't know if you have any.
Yeah, I don't know the exact numbers. I know that our attrition rate, at least within our dignity sponsored medical group, is fairly low.
It's actually gotten a lot lower. Over COVID, we lost a lot of practitioners and nurses and everything because people who were close to retirement retired. People, wanted to leave the profession. But luckily, we've rebounded some from that. We are getting better. We're not losing as many people each year and all. So fingers crossed.
I think for us, it's the spouse's job that
that's
plays
true,
a
too.
big factor in it. If their spouse has transportability with their job where they're able to work from home or whatnot, then we can keep those people here. But if there's no employment for them or they're a specific, niche in what they do, then they're going to go to a bigger city. And that's what we see internally, but we do ask what is the reason, and we kind of know as well as how they're working, and they cut down on shifts that they're committed to, so we get the idea. And then but usually it's the significant other component of it, and like Sue said, lack of family support to raise families here, having to get childcare and bringing their extended family to help them care for their children. So those are the big reasons why.
COVID did help us though, in that more spouses now seem to work from home than they used to. So that has been kind of a good thing. And the other thing that's kind of interesting is we have a number of physicians here and throughout here that their father was a physician, or one of their family members was a nurse or whatever. And we have them now working here as physicians. And usually when that happens, they stay too, which is great. We love multi-generational.
Yeah. So mostly for our team, it's the physicians who were born and raised here. We have about 4 or 5 of us that not myself included, but other people who were born here, went to the schools here, they're, may have had they may have had a physician in the family, but they went and trained and then they wanted to raise their family here, and we brought them here. One of our hospitalists, the youngest one that we hired, I've been waiting for her for 4 years to graduate, because I knew about her from the cardiologist who had known her since she was a little girl. So, she says, just wait for her 4 years. I said, okay, I'm waiting 4 years. Finally, she graduated, and this was the first place she came.
I had 2 questions, but I don't think Dr. Ryan's here. I don't know if you can answer it, but pulmonology was a really difficult situation. And I'm wondering if it got better for outpatient.
Really good question. So here in San Luis Obispo, we have Dr. Saul, who is doing some part-time outpatient work. We just recruited a new pulmonologist from UCLA. She just graduated from UCLA. Dr. Ramsey, and she's amazing. She's right now our outpatient clinic that she's in down in Santa Maria. So we have 2 full-time, well, no, I should say 1.5, because she's working part-time there, and then part-time she takes shifts on the critical care unit here. But the hope is that we may maybe set up a pulmonology office in Aurora Grande or somewhere halfway in between, because we're short everywhere, pulmonologists, and I don't know how long Dr. Saul is going to be doing it, so we need to kind of plan
and
for
there was a nurse practitioner. Is there still a nurse practitioner? Pulmonology.
I don't know.
I think he went off on his own, the concierge type of.
Oh, okay.
Sellers, right?
I can't remember.
Yeah.
Dave
Sellers.
Okay, so that was one question.
Yeah, because we do have PAs down there too with the pulmonologist. So if you can't find anybody anywhere, they can take you down there. The only problem is you have to drive to Santa Maria, but it's 2 physicians that are both very good.
And then I just was a little confused when you were talking about the new cancer center and having the CT scans and all that. But is the San Luis diagnostic staying exactly the way it is?
Yeah,
so
it is. There's enough need
just for cancer.
Well, or imaging, like if you go to the general surgeons or the urologists and you need a scan, you can get it right there in that building. Okay. But I don't know if any of you had to get an MRI, but there was a while where MRIs were taking months to get in. And so our hope is that this will just help relieve some of that.
Okay.
Yeah.
Yeah.
So you mentioned the payer mix is very favorable around here. Low,
yeah, compared to other hospitals.
Compared to other places. But with Medi-Cal, with CalAIM and expansion, and I think the mix is going to change some, and we're going to see more Medi-Cal folks in the greater community. How are you guys planning for handling the very poor reimbursements that you get from them, but they still show up?
Yeah, so St. Cal handles all of our Medi-Cal pretty much on the Central Coast. And I will say we're fortunate to have St. Cal in the chair of their board this year. And it's so much easier to deal with them than it is state Medi-Cal. So I think our enrollees and stuff are really lucky that that's their coverage. But I will tell you, like at Marion Hospital, we have a much higher percentage, if you can understand the demographics, we have a much higher percentage of Medi-Cal. So we are used to working in that kind of environment. So, I feel like we're well set up for that.
Montero,
yeah, it's tough. I mean, I'm hopeful that mix doesn't change too much, because we don't get paid our cost even for Medi-Cal, so it costs us more to take care of a patient than what we get paid. So you can understand you can only have so much of that.
Does the county not pay for some of that?
County doesn't. They used to, yes. Yeah, you're right.
They don't do any?
No, it all with the Affordable Care Act, it all went to Medi-Cal, but now it may all shift back and everybody's saying kind of, well, what about the county responsibility? And they do have responsibility for that, but I don't know what they're gonna decide to do. Because right now, they're not funding any of it. And a lot of you might remember the old general hospital and stuff. I mean, there was a lot funded by the county in the past.
Yeah, so we have time for one more question if you want to. Yeah.
Great, look at 30 seconds. Well, so I actually work with the Alzheimer's Association, so we partner a lot.
Yes.
And, or at least refer back and forth often. And I guess just in that, particularly in caregivers that I speak with every day, we know there are long waits for many things. And I guess just what considerations are you all dealing with as far as facility for dementia-friendly types of spaces, both with the ER, having the new tower, as well as in clinics and training for staff? There's a lot.
That's a couple of things I think of, and I'll let you say, but for one thing, it'd be great to talk to you and see maybe what things we should consider for the future in our rooms. But I would think that having private patient rooms are going to be so much better for patients, less stimulation from too many people and too many people walking in and out. So the biggest thing I think we can do is have private rooms, and then where a caregiver can also be in the room if they need to be. Is going to be a huge help for our providers too.
Yeah, the private rooms are helpful. You know, there are things that we do right now by putting them near a window so that they get some natural light, you know, because there's always, the lights are always on in the hospital, so you get disoriented. So there are some things that the nursing staff is able to provide right now, you know, immediately while the patient is in the hospital. But it is a huge thing, you know, it's heartbreaking to see they have this underlying disease and they come into the hospital and they get worse and they clinically deteriorate because a lot of this is just, you know, their disease process. And so that would be super helpful to, you know, have individualized rooms where they're able to not be around so much stimulation.
So thank you all so much for coming this evening. We really appreciate it. We hope that you are inspired by what you heard and maybe take some of this information, the exciting news, the upcoming projects, all of the intel you got from the experts here today, and be ambassadors in the community with your neighbors, in your place of work, at your churches, wherever you go, and share the good news that we shared today about what's coming down the pike for French Hospital, because it's monumental. It's a historical moment that we're actually going to get this tower built. We'll be the first and only hospital in San Luis Obispo County with private patient rooms. And on that note, I wouldn't be doing my job if I didn't mention, and I know Sue earlier mentioned that, you know, somebody could name the outside of that building for $15 million, but I know that's unattainable for most, but I wouldn't be doing my job if I didn't say that we do also, you know, welcome if you or if somebody you know might have an interest in naming one of the private patient rooms that we are building. We would be more than happy to put your family name on one of those rooms, and that's a $25,000 commitment. We often will do pledges, so a 5-year pledge, $5,000 a year for 5 years, could have your family name on a private room in the new tower. So it's a nice way to leave a legacy, something to consider. So again, wouldn't be doing my job if I didn't mention it, but more than anything, what we hope is that you will take this information back to your communities, your spheres of influence, and inspire other people to get involved. Please contact us if you have any questions or want to dive a little deeper into some of the information you heard tonight. We're more than happy to answer questions. We're more than happy to conduct tours of the hospital, sit down and chat with you, learn more about what your needs or barriers might be to getting care or getting access to care. So we're here to help you. That's our first and foremost responsibility to this community, is to provide excellent care and to offer support to each of you. So thank you for your time. We're here to answer questions afterwards as well, but take some goodies on your way out and enjoy your evening.